Hello everybody. Over the next few minutes we will discuss whether it's time to be thinking about using MRI for prostate cancer screening. So what we're going to do over the next half an hour or so, we will review the rationale for population screening for prostate cancer, focusing on the role of MRI. I'm going to try to show you that the harm reduction benefits of MRI that we see in secondary care also apply in primary low prevalence screening without impairing the detection of clinically significant disease. But most of my time I'll spend on how we optimize the MRI examination and the challenges that we face in implementing an MRI diagnostic pathway. So here are my disclosures. Now, we know that the incidence of prostate cancer is increasing, and there are an increasing number of late presentations. So if you look on the right-hand side, you can see that there's been a 3% increase in prostate cancer incidence year to year from 2014 to 2019, such that we almost have 100,000 diagnoses of prostate cancer in the USA, for example, per year. And you can see on the bottom that the prostate cancer deaths are about 33,000 a year. And these deaths, by and large, are caused by the late detection of high-grade cancer. So high-grade and very high-grade cancers make up about a fifth of the diagnoses, but in fact, over 10 years make up about 2/3 of the entire mortality of prostate cancer. So it's this small group of high-risk cancer that causes the majority of the deaths after 10 years. So why don't we just do PSA screening and find them and just look at the whole population? Well, we now know that case-finding strategies where we just use a single time point don't work, and there's really good evidence around this because many cancers are not found. What we do know is that if we do regular screening, that we can reduce prostate cancer mortality by about 20% over 17 or 18 years, and I'll show you the evidence for that in a second. But we still don't use prostate cancer screening using PSA because the harms associated with the overdetection of indolent disease outweigh the benefits of decreasing mortality. And I just wanted to illustrate that to you in a second. So let me just show you that prostate cancer can in fact decrease mortality. Prostate cancer screening can decrease mortality over time. So here is the European study looking at 182,000 men over 18 years. And you can see over 18 years that if you underwent screening, there was a 20% reduction in the overall mortality associated with prostate cancer, and the number of men you need to diagnose to prevent one death has been coming down and down and down, and currently this is 18. But overdiagnosis remains a really big issue, and that's, I think, shown quite well in this central graphic. So if you were to invite 10,000 men without screening and with PSA screening, you can see that on the second row that about 17 lives would be saved with screening. The problem is the harms, and the harm you can see is that 315 men would be diagnosed with a cancer that is unlikely to cause the patient harm, and these 315 men would undergo some sort of treatment. It could be active surveillance, it could be surgery, it could be radiotherapy, and all the side effects associated with those treatments. And that includes anxiety of having cancer, incontinence, impotence, etc., etc. And you can see how the ratio just doesn't stack up for doing PSA screening followed by a systematic biopsy because of the harm. So we can do something about this, of course. We can stop doing blind systematic biopsies. For this group of men, we can use MRI after a PSA test to try to reduce the number of biopsies that are done. We can use an MRI targeted biopsies if we see something. We know that there is if you have indolent cancers or even favorable intermediate risk grade group 2 cancers, a lot of these patients can undergo active surveillance, and there's now quite a high take-up of that. So that can be quite useful, and of course focal therapies for these smaller cancers is also coming in. So we have strategies that can reduce harm over time. And in fact, the EAU, the European Commission, in fact, in 2022, came out with this statement. It initially recommends that it says that prostate cancer screening programs should start, and they recommend that PSA testing be done in men up to 70 years of age, and then an MRI as a follow-up before any biopsy. So you can see there's a shift towards the use of MRI in the diagnosis paradigm in the primary screening setting. Now, let's just briefly look at the benefits of MRI, not in primary screening, but in secondary care. In secondary care, we know that the prevalence of clinically significant disease, defined as grade group 2 or above in a urological outpatient, is about 20 to 50%. And if you were to use MRI in this setting, we could reduce the number of men undergoing a biopsy, and you can reduce diagnosis of indolent cancers. And we know this to be the case, and there's level 1 evidence to support this. Now, we also know that using MRI targeted biopsies is more accurate, and we know there is a non-inferiority of disease detection, particularly in biopsy-naive men. In other words, if you use an MRI and you use that to target a biopsy, the number of clinically significant cancers is as many as you would get with systematic biopsies. In other words, it's not inferior. Now, of course, that applies to this prevalence of 20 to 50%. The real issue in this instance, of course, is what does it equally apply to the screening population? And of course, in the screening population, the prevalence is much lower. It's about 3 or 4%, and I'll show you some evidence around that. And of course, if you pre-screen with a PSA test, depending on where you set your PSA threshold, then of course the prevalence would actually increase. So you can see a couple of studies on the left-hand side in the screening setting, and on the right-hand side in the secondary care. Now, one of the things you notice is the number of men avoiding a biopsy increases. The number of men avoiding a biopsy increases with lower prevalence situations, which is exactly what we want. You can also see on the left-hand side that the number of men who have insignificant cancer is also decreased when using an MRI strategy. So let's just focus down on this study here on the left-hand side to have a look at that in a little bit more detail, looking at primary screening. So here is the trial setup. You can see that in this particular trial, you can see the prevalence was 3%. Okay, so men more than 50 years of age with no prior history of PSA screening were just randomized in Canada. And this was an early study, and you can see that you had about 250 men who had MRI, and you had 250 men who had PSA screening. And you can see that those who had PSA screening underwent a systematic biopsy. Those who had an MRI that was positive, a PIRADS 4 or 5, underwent a biopsy. So we can compare who got a biopsy, what the rates of detection of significant and insignificant cancers was for this strategy. Now, one of the most interesting results is that you'll see that the number of men who accepted a biopsy after an abnormal PSA test, in the blue in the middle panel, was less than the number of men who accepted a biopsy after an MRI was positive. In other words, if you can see something, then men are more likely to accept a biopsy. So that's one of the key results, that it improves the compliance for biopsy. If you look on the right-hand side, you'll see that the number of men who had no diagnosis of cancer was lower with the MRI, and that's in the middle panel. You can see that there were fewer benign biopsies and there were fewer insignificant cancers. But look on the right-hand side of the graph. In fact, there was an increase in the detection of clinically significant disease. So there was a higher rate of the detection of clinically significant disease in this group of men. But this is a small proof of principle study, but it does show that MRI improves compliance and also reduces harm associated with a raised PSA with systematic biopsy. So let's look at the next study. In this case, different to the prior study, men were chosen for an MRI after a raised serum PSA. So let's just look at this in a bit more detail. So again, this is in the screening setting, and you can see that 12,750 men were invited for screening, of which 12% had a raised PSA, in this particular instance greater than 3 nanograms per ml. These men were randomized. They were randomized to either systematic biopsy or an MRI biopsy with systematic and targeted cause if their MRI was positive. So you had a systematic arm and then you have the MRI arm, where only men who have a positive MRI undergo biopsy. And you can see the results here. So if you look on the right-hand column, you can see that the number of biopsy procedures is less using the MRI approach, which is exactly what we thought would happen. You can also see that the number of benign biopsies is less for the MRI approach. You can see that the diagnosis of indolent cancers is less for the MRI approach. And if you look at the detection of clinically significant disease, its MRI is not inferior. In fact, in this particular graph, it shows slight superiority, 18 versus 21%. I mean, this came out as statistically significant because it's quite a large study. But you can see it's certainly not inferior. So you are detecting the cancers using the MRI approach. So it looks as though it is worth going for the MRI approach, and you can see that that PSA threshold in this particular instance was 3 nanograms per ml, which means in this particular instance 12% of men who had PSA screening then came into this approach. So this is the reason why the EAU pathway prostate cancer screening says that you should have an age-adjusted PSA followed by a clinical risk assessment, and you can see that over here. So at the top is the age-adjusted PSA, here is the risk assessment, and then if you are still considered at intermediate or high risk, and those people who have an abnormal DRE, they undergo an MRI, and if you are positive on your MRI, then you undergo a systematic plus a targeted biopsy. Now, if you were to do that, what would be the proportions of patients moving in different directions? One of the figures that I pointed out to you earlier was the number of men who would have a PSA greater than 3. And roughly it works out between 10 and 12%. I've seen one trial where it was about 7%. So it's a small fraction of the men who come for PSA screening who would then plug into this. After risk stratification, you could do that with PSA density or a risk calculator or some other test, and we'll talk about that in a second. About 35% of men avoid an MRI. And then these men will then go in to have an MRI, and a lot of them will just have a negative MRI. About 57% will avoid a biopsy after an MRI. And then the rest will go and have a biopsy, about 43%, and 8% will be found to have a non-significant, to have no cancer. So in other words, the majority will have some sort of cancer because you've undergone 2 risk stratifications, and you see that the majority of the cancers that you detected will be clinically significant rather than insignificant. So you can see how this triage is enabling you to find and enrich the population to men who have clinically significant disease. And this is how it works. So this pathway is what is being thought about as something that we should adopt. Of course, this means that there are problems for radiologists. So, for example, what is the optimal age for screening, and does that match the optimal age for MRI? Interesting. Can we further reduce the number of MRIs that we have to undertake by using some other way of risk stratification? Should we use contrast or should we not use contrast? And what is a positive MRI and what is a negative MRI in this setting? What type of biopsies should be done after the MRI? How are we going to integrate this into MDT working, and how are we going to build capacity? What's going to be the role of AI, for example? How often do we repeat this process? These are all outstanding questions. So there are optimization and pathway challenges for MRI, which is what I want to focus on for the rest of this talk. So the first question to ask is this cutoff value of 3 nanograms per ml the right cutoff? In other words, we're saying, well, how many men in this histogram have cancers when their PSAs are less than 3, and how many men have more than 3? And that's an important question. And in fact, this was looked at recently by the prostagram study. So the prostagram study again was done in population screening setting, and you can see about 10% of men had a PSA greater than 3, which is exactly what we said would happen. Now, in fact, these men had a PSA test, they had an MRI test, and of course they had an ultrasound test. So regardless of which test they had, if it was positive, they had a biopsy. And so a lot of men had a biopsy. And then they had transperineal systematic biopsies, and if their MRI was positive, then they also had targeted biopsies. So this is a well-conducted study in an unselected population, because we want to see how many men had cancers in the 3 and above group and how many had below 3 and above. And this is the trial schema. So you can see that 2,000 men were invited for screening, and we compared what happened to these men. So you'll look on the right-hand side, you'll see that 41% of men underwent a biopsy. Now, of course, that's a lot. But we are looking to see how many cancers there are in the population. So we want to excessively biopsy these men. And interestingly, you'll see that 40 men had a PSA greater than 3. But you'll see if you used an MRI score and looked at that, 3, 4, and 5, you'll see many more men had a clinically significant lesion on an MRI if you use 3, 4, and 5. If you just use 4 and 5, you'll see it's very similar to the PSA test. So in other words, a lot of people here had a PIRADS 3 abnormality. So let's look at the number of men who had clinically significant disease, in other words, this right-hand box. I'm just going to magnify that up for you. So if you look at this very carefully, you'll see that 17 men overall had clinically significant disease in this population. Okay. Now, if you look at what test detected the most number of cancers, it's certainly not the PSA test. You can see the PSA test detected in total 7 out of 17 cancers, whereas PIRADS 3, 4, and 5, so remember 3, is in this group detected 14 of the 17 cancers, but if you use only PIRADS 4 and 5, you detected quite a lot of the cancers, so 11 out of the 17. So if you can then start to model what were the pickup rates depending on which strategy you used. So if you were to use a PSA of greater than 3 and then do systematic biopsies, the number of biopsies you'd end up doing is 10%. Okay, fine. This is exactly what we said. But your cancer detection rate will be 1%. Okay, but we know that strategy works, right? We know that survival, if you follow these men over 20 years, they will have an improvement in survival. So that is a strategy that we know works, and there's level 1 evidence to support that. But look at the MRI strategies. All the MRI strategies are better than that strategy. So for example, if you looked over here and said, okay, I'm going to take a PSA of 1 or above, and I'm going to do an MRI of PIRADS 3, 4, and 5, then actually you'll see that the cancer detection rate goes up at the expense of more biopsies. And of course, clearly, we don't want more biopsies because we're trying to avoid overdiagnosis. We want to be to the left of that. So we want to be to the left of this line in this area. So what about these strategies? Well, if you look at that strategy, and that strategy is a PSA of more than 3 and an MRI of 4 or 5, that's pretty good. That's pretty good. You can see that the number of biopsies you undertake is less than 5%, and the cancer detection rate is slightly higher than using PSA and systematic biopsy. So it's better than the PSA and systematic biopsy, but in fact the optimal strategy appears to be a PSA of 1 and an MRI of 4 or 5. That gives you the greatest detection rate of about 2.5% at a lower biopsy detection biopsy rate of about 7.5%, as you can see here. So that might be the best strategy. So you can see how you can use modeling like this to decide who would be the best person for an MRI. Now, is it possible to make that even better? Can we reduce the number of MRI scans even more by using other factors such as family history or nomograms, or even something called the polygenic risk score? Well, one of the polygenic risk scores that's available is called the Stockholm 3 study. So the Stockholm 3 study looks at clinical variables, which include age, family history, previous biopsy results. It looks at a number of blood proteins and genetic markers, including 101 SNPs, single nucleotide polymorphisms. And this seems to have level 1 evidence, which is why I'm showing it to you here today. So let's just have a look at the study data using this polygenic risk score. So again, you can see this was done in that setting of screening. And you can see that about 12,000 men who were asymptomatic accepted screening with either a PSA or the Stockholm 3 test. And if you look on the right-hand side, you can see that this test, the Stockholm 3 test, is better than PSA. Now, we know that PSA is great, right? Level 1 evidence. But this is better. And you can see it there on the right-hand side. So the Stockholm 3 test is better than a PSA and systematic biopsies for detecting clinically significant cancers while reducing the number of indolent cancers, and we'll come to the figures in a second. And the Stockholm 3 test is better at reducing the number of MRIs that you also undertake. So not only can you pick up more cancers, decrease the number of clinically insignificant cancers, but you can also reduce the number of MRIs that are done. So let's just look at the data in a little more detail. And here is the data from that study. So you can see 12,750 men. You can see either PSA or the Stockholm 3 test was positive in about 18%. And if you look at the benefits, for example, let's talk about reducing harm, you'll see compared to systematic biopsies, which is the reference standard, level 1, you see that an MRI targeted biopsy when the PSA is greater than 3, or an MRI targeted biopsy when the Stockholm 3 test is positive, is lower than systematic biopsy. So you can see the number of biopsy procedures goes down, the number of unproductive biopsies goes down, the number of insignificant cancers also goes down. What about the detection of clinically significant cancers? That stays up. In fact, it gets better. So you can see that the detection of clinically significant cancers actually increases. But look at the number of MRI procedures. You can see that the number of MRI procedures drops if you use the Stockholm 3 test. So what we're saying is that actually there may be a better way of reducing the number of MRIs you undertake if you pre-screen not only with PSA, but also the Stockholm 3 test. And that, of course, depends on how much the Stockholm 3 test actually costs. Now, other things that we need to think about is whether the age at which screening is undertaken is optimal for the MRI, and that's important. Whether we should be performing biparametric or multiparametric MRI, and as I've already said to you, what is the best cutoff for a positive, negative result in the screening setting. Now, this is a very nice study that was published recently. And what that shows, and it shows on the graph on the right-hand side, is that the older you get, the better MRI is for the detection of clinically significant cancers, because you get cystic atrophy in the peripheral zone. So as the prevalence increases and the peripheral zone becomes more atrophic, cystic atrophy, then cancers pop out and we see them better. And so it turns out that the age at which we want to screen matches very well the age at which the MRI is the optimal test anyway. So actually, it's thumbs up, because it looks like the optimal age for the use of MRI coincides with the optimal age for screening. So that means MRI is good. What about using contrast? Now, we often say we should give contrast, particularly in secondary care, because of course the prevalence is high. And we already said this is between 20 and 50%. So we should be using, and the PIRADS committee recommends, the use of contrast enhancement in secondary care. But what about primary care? Well, in primary care, what you don't want to do is overdiagnose cancers. So when you have a lower prevalence, such as in population screening, then you probably do not want to be using a contrast medium. Of course, the quality of the scan and the quality of the reporter must be assured. Okay, but the important thing is that for the screening situation, we do not probably need to use IV contrast, because we don't want to overdiagnose cancers using dynamic contrast enhancement. Remember, when you give contrast enhancement, most of what you find is grade group 1 or microfocal grade group 2 cancers. And these are cancers you do not want to find. So it's probably better to leave the DCE. And what about the threshold at when you call an MRI positive or negative? Now, generally speaking, for secondary care, prevalence is higher. We're more concerned about the presence of cancer, so we tend to use 3, 4, and 5 as the cutoff. This means that we have less false negatives, harms, and so they are suitable for patients who are scared to death of cancer averse patients. Now, remember, in primary screening, you have biopsy averse patients. Your patients who only want a biopsy if you can be sure there is cancer there, right? So 4 and 5 is a better threshold in primary screening because the prevalence is much lower. So it's important to think about this as we think about what is a positive and what is a negative test. And then the question arises, which is the best biopsy method if you see something on an MRI? Should you do systematic biopsies for these men? Should you do a targeted plus systematic biopsy, or should you just do a targeted biopsy? These are important questions for the pathway. And this was looked at again in the screening setting in this recent study. And you can see here that 1,200 men had a PSA greater than 3 nanograms per ml. And you can see again that figure of 7%. So remember, I've shown you 7%, 10%, 12%. So these are the number of men in the population who are likely to have an elevated serum PSA. And in this particular study, there was a randomization to the reference group. Now, the reference group was people who had a systematic biopsy and a targeted biopsy if an MRI was positive, versus the experimental group in this particular instance was targeted biopsies alone. And there was a randomization. And the figures are shown on the right-hand side comparing systematic plus targeting versus targeting alone. And you can see that the number of men having no cancers was lower in those men in whom you just did targeted biopsies. And that's the second column. So the number of unproductive biopsies is lower for men undergoing a targeted biopsy. You can see that the detection of insignificant cancers is lower if you just do a targeted biopsy, which is exactly what we expect. You can see it's reduced by about 50%. What about the detection of clinically significant cancers? And you can look on the right-hand side of that graph, and there you can see there's a slight reduction in the detection of clinically significant disease if you were to do targeted biopsy alone. And when you look more carefully at that, that's not statistically significant, by the way, but if you look at that, you'll see there were only 10 men in that particular group, and they were all grade group 2 and above, and 6 of those men, in fact, were treated with active surveillance. So, in fact, those cancers that were missed were probably not as significant as we realized. They certainly weren't the larger cancers. Now, what's going to be the role of AI in all of this? And clearly we are going to need AI for population-based screening. So we can imagine that an AI could play a number of roles, and these are outlined over here. But what I'd like to do is just talk about data acquisition and analysis. We don't have time to have a more in-depth discussion. We certainly have AI accelerating data acquisition. And you can see a biparametric MRI on the top, and at the bottom using AI techniques and non-AI techniques. So if you just did a conventional biparametric MRI, in this particular instance, it took 12 minutes and 30 seconds roughly. And you can see using the AI reconstructions on the bottom, we can make that into 5 minutes and 30 seconds. So in other words, it becomes very feasible using MRI for data acquisition to have a 10-minute time slot. And of course, that's important from a radiological perspective. But what about for analysis? Well, here's a man who was incidentally found on it was asymptomatic, had a PSA test and was found to be 2.5. And you can see this abnormality. This PIRADS 3 lesion, right? And I told you there would be an excess amount of PIRADS 3 in these patients, and here is an example. Now, if you look at his PSA density, see it's 0.04. And so what is the chance that this is a clinically significant cancer? Well, if you look at the EAU table and try to estimate what the prevalence of clinically significant diseases in a PIRADS 3 with such a low PSA density, you'll see it's about 4%. So in other words, it's about what you'd expect in the background population. So in fact, you want to downplay this. You could say, put this data into a nomogram, and here's a very good nomogram that I sometimes use. You'll see the predicted probability of a high-grade cancer is 7%. So it's about the same figure of 4% that we were talking about. So the likelihood of this man having a clinically significant cancer is low. If you put this into an AI, you'll see that the AI says that the level of suspicion for that lesion on the right-hand side is 81%. That is a problem. That is a problem because the AI system, remember, was developed for secondary care at a much higher prevalence. And this particular AI was trained for a prevalence of about 50%. So it has seen something like this at a prevalence of 50%, and it knows that that abnormality should be suspicious in that group. But if you apply it to a lower prevalence population, then it'll give you the wrong answer. In other words, what I'm trying to say is that AI systems that have been developed for secondary care will need to be retrained, adjusted for populations where the prevalence is much lower. Otherwise, the AI, in terms of the analysis, will begin to mislead us because we want to reduce the number of false positives. So you have to be really careful about taking an AI developed for secondary care and applying it to primary care. And one of the questions that always comes up is, MRI is too expensive for this role. Is it going to be cost effective? And of course, you're right. Screening requires a huge resource allocation, a large infrastructure, and MRI just adds to the operational costs. And of course, it has a capital investment and all the biopsy procedures that follow there afterwards. But of course, there are multiple factors that determine what the cost effectiveness of this is. But luckily, the cost effectiveness studies have in fact been done. So I've shown you two studies here looking at the cost effectiveness of using the MRI approach. So on the left-hand side, there's a comparison of three strategies. One is no screening. The second is just using PSA with a standard systematic biopsy. And the third strategy here is PSA with MRI. And if the MRI is positive, then they undergo a combined targeted plus systematic biopsy. Now, the graph on the bottom needs some explanation. You'll see that if you're willing to pay $50,000 US for one quality year of life, you'll see that the worst, compared to a PSA and standard biopsy, which is this line here, an MRI strategy, in this particular instance in blue, is 40% more likely to be cost effective. That's interesting. So this is the strategy that we know has level 1 evidence. You add MRI, there's a 40% probability of being more cost effective than using the systematic and targeted biopsy. So we know this strategy has level 1 evidence supporting it. Actually, this suggests that the MRI, at least in Sweden, would be cost effective at that price point. Look on the right-hand side. So this is looking at a similar group of patients, but looking this time at not only PSA, but also looking at the Stockholm 3 test, which we said would further reduce the number of MRIs that were done. So we're comparing 3 strategies here. So strategy 1 is PSA, followed by MRI. And if your MRI was positive, you underwent a targeted and systematic biopsy. That's the same strategy as this, in other words. But there are other strategies here, strategy 2 and strategy 3. And here they've just used different levels of the Stockholm 3 test. So a PSA is positive, then you don't go to an MRI, but you undergo a Stockholm 3 test. And if the Stockholm 3 test is also positive, then you undergo an MRI in a similar way. And this is just using different thresholds. Now, again, if you look at a similar price point at, say, $50,000 US, or it'll work out in this particular instance as 50,000 euros. If you look over here, you can see that this is the MRI strategy here, which was more effective than no screening. So if you do no screening, then compared to no screening at all, using a PSA and an MRI is more likely, 25% more likely, so has a higher probability of being cost effective. But if you were to add the Stockholm 3 test, that probability increases even further because, of course, you're doing fewer MRI scans. So there are ways of making this not only with fewer MRI scans, but in fact more cost effective using pre-test protein tests such as PSA and the Stockholm 3 test. So actually it looks like it probably is cost effective, particularly in Sweden. We need to see similar data from other countries to check that this approach using an MRI is in fact cost effective. So these are my take-home points. There is no doubt, and I think the level 1 evidence confirms this, that MRI lowers the harms of overdiagnosis after PSA testing in population screening at baseline. Will this still apply after multiple rounds of screening? We don't know that, and there is no data published around that figure, and something that we need to bear in mind. Clearly, we need to take into account not only PSA, but the age-adjusted PSA. We need to take into account racial profiles, family history. It seems likely that in higher income countries, we're going to be using genetic tests, such as the polygenic risk scores and imaging when we do biopsy decisions. I don't think there's any doubt about that. Clearly, there are challenges for MRI and the MRI-Pathway that we still need addressing. The MRI-centered approach can be effective, and it looks like it probably is cost efficient. What we don't know yet is whether the MRI involvement in this pathway will in fact save lives in the longer term. We expect it will, because a PSA and a systematic biopsy alone does, and MRI is better, and I've shown you several pieces of evidence saying that MRI actually is better than systematic biopsy, so we expect it to do that, but of course we don't have the data. It will take more than 15 years, and we'll begin to see the first results of the studies after 2030 or so. I hope you found some of these comments useful as you start to think about the next stage in the development of MRI for prostate cancer screening. Thank you very much for listening. Bye-bye.